Hello everyone. Today we are going to learn a very short topic but very important topic, that is renal hypertension. So the management of hypertension in renal diseases is slightly different from a normal hypertensive patient. There are different pathogenesis of hypertension and in kidney diseases patients. So today we will discuss about the pathogenesis and treatment of hypertension in patients with acute as well as chronic kidney diseases. In acute kidney diseases, there is a different mechanism for hypertension, and in chronic kidney diseases, there are many factors which contribute to hypertension. So, pathogenesis of hypertension in kidney disease patient varies. It depends upon the type of disease and the severity, whether the disease onset is acute or chronic, and it also depends upon the type of disease. So in kidney diseases we will have glomerular origin of disease and the vascular origin of diseases. Both have different pathophysiology of hypertension. So in case of glomerular diseases which has acute onset, such as seen in acute post-streptococcal glomerulonephritis, the patient will be volume overloaded, patient will be edematous because of sodium retention. There are multiple reasons for sodium retention in case of glomerulonephritis. So mainly in glomerular diseases, the hypertension is due to edematous state or volume expansion, which is mainly due to sodium retention. So hypertension is due to volume overload in case of acute glomerular diseases. Glomerular diseases are usually low renin hypertension states. Renin angiotensin activity is low in case of acute glomerular diseases. So these patients are mainly volume expanded because of sodium retention, and this is a low renin hypertension state. In case of acute vascular diseases such as seen in scleroderma renal crisis or vasculitis, there is ischemia which induce the activation of renin angiotensin system. That results into hypertension. So in case of acute vascular diseases such as vasculitis or scleroderma renal crisis, there will be ischemia which leads to activation of RAS, which results into hypertension. There is no volume overload in acute vascular diseases. So in acute glomerular diseases, hypertension is mainly due to volume overload, and in acute vascular diseases, hypertension is mainly due to RAS activation. So we have different pathophysiology of both these diseases, and we have different treatment options depending upon the pathophysiology. Now coming to chronic kidney disease. In chronic kidney disease, hypertension is because of multiple reasons. The important ones are sodium retention. In CKD patients, there is defect in tubular secretion of or tubular excretion of sodium, so there will be sodium retention. Increased activation of renin angiotensin system. There is secondary hyperparathyroidism also in chronic kidney diseases patient, which results into hypercalcemia, which can cause vasoconstriction and hypertension. There will be impaired nitric oxide synthesis in uremic patient, which also results into vasoconstriction. So there will be in chronic kidney diseases patient, multiple mechanisms are responsible for hypertension. Important ones are sodium retention, increased activity of renin angiotensin system. There will be secondary hyperparathyroidism which can result into vasoconstriction as well as hypertension. And in uremic patient, there is impaired nitric oxide synthesis. In end stage renal diseases, they usually seen increased central venous pressure, mainly in elderly patients because of increased aortic stiffness. So end stage renal diseases, there is slightly increase in the central pulse pressure because of increased aortic stiffness. Hypertension itself leads to hypertensive nephropathy, which further involved in poor control of blood pressure in CKD patients. And one more important reason is in CKD patient there is no nocturnal decline in BP. In normal patients there is midnight decline in BP, but in CKD patient no nocturnal decline in BP since they are known as non-dippers. So in CKD patients, important causes of hypertension are sodium retention, increased activity of RAS, secondary hyperparathyroidism, impaired nitric oxide synthesis in uremic patients, end stage renal disease have more central pulse pressure because of increased aortic stiffness, which can result into isolated systolic hypertension. Hypertension itself results into hypertensive nephropathy, which further aggravates the blood pressure and which further results in poor control of blood pressure. CKD patients, there is no nocturnal decline in BP, so these patients are also known as non-dippers. So this is all about the pathogenesis of renal hypertension. In acute glomerular diseases, hypertension is due to volume overload or edematous state due to sodium retention. In acute vascular diseases, RAS mainly is culprit. Renin-angiotensin system is responsible for hypertension. In CKD patients, there are multiple mechanisms for hypertension. So this is all about the pathogenesis. Now coming to the treatment of hypertension in CKD patients. So first we will discuss about the goals of what are our goals of BP control in kidney disease patients in CKD and acute kidney disease patients. So in case of kidney disease patient, we require a tight control of blood pressure so as to decrease the proteinuria and to decrease the progression of the disease. So in kidney disease patients, control blood pressure is very important to decrease the proteinuria and to slow down the progression of the disease. Our goal should be less than 130/80 mmHg. So blood pressure should be less than 130/80 mmHg. Second is we have to reduce the proteinuria. So we have to decrease the proteinuria to less than 1 gram per day, that is 1000 milligram per day or 1 gram per day, or 1 gram per gram of creatinine. The first is we have to control the BP, that is less than 130/80. Second, we have to control the proteinuria by regulating the blood pressures. So proteinuria should be less than 1 gram per day or less than 1 gram per gram of creatinine. In patients of nephrotic syndromes, or if there is nephrotic range of proteinuria, so our goal should be we should try to decrease the proteinuria to at least 50 to 60% from baseline, and or protein excretion should be less than 3.5 gram per day. So overall we have to decrease the protein to less than 1 gram, but if patient already has nephrotic range of proteinuria, that is more than 3.5 gram per day, then we have to try to decrease the proteinuria by 50 to 60% from baseline, or total protein excretion should be less than 3.5 gram per day. One most important thing in controlling the blood pressure in kidney disease patient is sodium restriction. So sodium should be restricted to less than 5 gram per day. So like we have already discussed, in glomerular disease the main problem is sodium retention, which results into volume overload. Sodium restriction is very important in treating hypertension in kidney disease patients. So these are the main goals. So blood pressure should be controlled to less than 130/80 mmHg, proteinuria to less than 1 gram per day. In case of nephrotic range of proteinuria, we should try to decrease the proteinuria to 50 to 60% from baseline, and one most important thing is sodium restriction to less than 5 gram per day. So now what are the drugs that should be used in treating the patients of hypertension with kidney diseases? So in case of acute conditions, there are different treatment options available for acute and chronic kidney disease patients. So in case of acute condition, in case of acute glomerular diseases, like we have already discussed, acute glomerular disease and hypertension in acute glomerular disease is due to volume overload condition. So we have to give diuretic. So in kidney diseases patient, loop diuretics are prescribed. loop diuretics, and out of loop diuretics, the diuretics which have longer duration of action is preferred. So torsemide is preferred over furosemide. Torsemide has a longer duration of action than furosemide. If patient edema is resistant to loop diuretics, then we can add thiazide diuretic. We can use add-on diuretics, loop diuretics plus thiazide diuretics. In thiazide diuretics, we have hydrochlorothiazide and chlorthalidone. But chlorthalidone is preferred over hydrochlorothiazide because it has longer duration of action and it is more potent than hydrochlorothiazide. So we can use combination of loop diuretics plus thiazide diuretics if edema is resistant to single diuretics. Kidney disease patients require a higher dose of diuretics. So furosemide can be used in a dose of 160 to 240 milligram per day. So what are the targets of using diuretics in a patient with kidney disease? So we have to either we obtain a target blood pressure that is less than 130 to 80, or we will try to achieve the dry weight. Dry weight is the weight at which further fluid loss symptoms, that is cramps, fatigue, hypertension, or unexplained elevation of creatinine, then that is the dry weight, the weight at which further fluid loss leads to symptoms, cramps, fatigue, orthostatic hypotension, or when there is unexplained elevation of serum creatinine. So till we have to increase the dose of diuretics. We have two targets to achieve IPP or the dry. So in case of chronic conditions, so first line therapy, in first we have to see whether it is proteinuric CKD or non-proteinuric CKD. In case of proteinuric CKD, the first line will be ACE inhibitors or ARB. So these so in case of chronic kidney diseases, we have to see whether there is proteinuria or no proteinuria. So in case there is proteinuria, the first line therapy will be ACE inhibitors or ARBs. So after starting ACE inhibitor or ARBs, we should look for serum creatinine and potassium levels. So there can be initially decline in GFR after starting ACE inhibitors. So regular monitoring of serum creatinine is very important. If there is increase in more than 30% serum creatinine from baseline after starting ACE inhibitors, so we should discontinue ACE inhibitors after ruling out other causes of increase in serum creatinine. So first line therapy in proteinuric CKD is ACE inhibitors or ARBs, but we should have it close watch on serum creatinine levels and serum potassium levels. It can cause hyperkalemia. Second thing is, if patient has edema plus proteinuria, the choice of therapy will be loop diuretics plus ACE inhibitors. If proteinuria is not controlled despite of giving ACE inhibitors or ARBs, so we can give non-dihydropyridines, that is diltiazem and verapamil. They have a very good effect on proteinuria, so they can be used as a third line therapy in case of hypertension in CKD patients. So first line therapy will be ACE inhibitors or ARBs, and if patient has edema, so we can add loop diuretics along with ACE inhibitors. Loop diuretics also considered as a second line therapy in renal hypertension. Next is non-dihydropyridines, that are dilzam or verapamil. So if BP still remained uncontrolled, so we can use a mineralocorticoid receptor antagonist, since there is hyperaldosteronism. So we can use spironolactone and apalerenone as a fourth line therapy in case of resistance hypertension. But these two drugs results into hyperkalemia. So we have to look for hyperkalemia and increase serum creat, as these drugs can worsen kidney functions also. So we should look for hyperkalemia and EGFR after starting mineralocorticoid receptor antagonist. And despite of all things, if BP is not controlled, we should start the patient on maintenance dialysis, because volume overload is one of the main reason for hypertension in CKD patients. So we should start the patient on maintenance dialysis if patient edema is resistant to diuretics or patient is still hypertensive after adequate medication. So we should start patient on maintenance dialysis. So this is all for today. Please like, share and subscribe my channel for more such videos. Thank you.